presentation. So my topic is currently this challenges in diagnosis and treatment of the lung cancer patients. So as we know, lung cancer now globally is the most one of the most common. It is the second most common after the breast cancer, and incidence is around each year new cases are approximately 11.4%, and the breast is 11.7%. So almost is one of the most common, along with the breast, the common newly diagnosed cancer. And second, we can see that the death of the each year there is approximately 1.8 million deaths in lung cancer patients. So and it is contributing around 18% of the total deaths in the cancer patients. So coming to this mortality wise, the lung cancer is the most common cause of the death in cancer patients. Then again, the lung cancer basically divided in the based on the histology, either a small cell or non-small cell lung cancer. So again, in the non-small cell lung cancer, there are many varieties based on just histology. So based on histology, it may be either adenocarcinoma, squamous carcinoma, or some other types of non-small cell lung cancer. And among these, adenocarcinoma is the most common, which is contributing around 40 to 45% of the cases. So coming to the total of 100% cases, 85% are generally non-small cell. And among these non-small cell, this adenocarcinoma is the most common type of lung cancer. And coming to the stage wise, if you can see that the survival of the patients who are presenting localized disease and distant disease, so it falls dramatically around 55% to less than 5% when patient present in the stage 4 type of lung cancer patients. So this is the global burden of 2.2 million and 1.8 million is the death. So again, this histologically it is either a small cell or non-small cell. Among these, the non-small cell is the most common, which is approximately to 85%, and out of this, majority around 40% are adenocarcinoma variant. And again, once we diagnose this lung cancer patient with a metastatic disease, either by tissue at the local site or a metastatic site, only diagnosing them with as either non-small cell or small cell is not enough. We need to categorize them further based on the molecular profile. Nowadays, whoever is posted in thoracic OPD, they know there are multiple treatment options based on the patient this molecular profile. Even those leave the molecular. In histology also, those patients who are having squamous, they can't be treated with pemetrexed or bevacizumab. And in squamous cell, there is a nivolumab drug is approved, currently not available, but histology also plays a minor role in deciding treatment if targetable or molecular treatment is not available. So while doing all these tests for diagnosing the lung cancer, each step requires some tissue. So, and again, taking the biopsy from the lung is very difficult procedure. So if you exhaust all the tissue only in the diagnosis, so for the further characterization for the molecular analysis like EGFR, ALK, there will be no tissue. So we need to, in the lung cancer patient, we need to biopsy sample very cautiously and try to minimize the sample testing as much as possible to preserve the sample for the molecular testing. But still, again, after doing all the ISC markers, sometimes it is not possible in 5% cases to diagnose the lung cancer. In this scenario, we need to take in all the clinical scenario and imaging method to diagnose, to suspect as a lung cancer patients. So again, only if we stay with the histology, the only recommended option are either conventional chemotherapy. But nowadays, in the last decade, the treatment has changed dramatically, and we have seen that the chemotherapy, the response rate was around 25 to 35%, either with the single agent or double agent platinum therapy or adding with or without bevacizumab. But now, with increased this understanding of the pathogenesis of the lung cancer, there are now multiple molecular targets are known, either EGFR, ALK, ROS or BRAF, and there are almost 14 to 16 driver mutations are known, for which we have effective drug which will give both life to the patient and quality to the life of the patient. So these are the therapies that target EGFR, ALK, ROS, and they have increased the progression-free survival, which leads to improvement in quality of life as well as overall survival. And a decade back, maybe there was a time when doctor was not treating lung cancer because their survival was hardly 3 to 6 months. But now with the improvement in the diagnosis and availability of these molecularly targeted therapies, the survival is now more than 60. If any targets are positive, maybe 40 to 60% of patients are surviving beyond 5 years. So these are very important. We completely diagnose the patient starting from the histology, then do the complete molecular profile. So this is just a general approach how we treat metastatic non-small cell cancer. So only just based on histology, we divide this patient in non-squamous or squamous. If non-squamous, then we do again molecular testing for EGFR all cross. Or nowadays we are doing that directly NGS. NGS is a testing where they do almost 52 or 200 or 1000 gene panel all together, so that the tissue wastage get prevented, and reports are also available in fairly rapid time. And if any driver mutation present, we treat this patient with the targeted therapy. If any targeted driver mutation is present, then we see a PDL1 to decide immunotherapy. And here I have not mentioned squamous cell, but nowadays Tata has shown in data that even squamous histology also has fair number of patients with driver mutation positive. So now our approach has changed. Even in squamous histology, we do all types of testing to see for the driver mutation. So all these histology or molecular marker or maintenance therapies are not independent. They are interlinked to decide the patient's monitoring and treatment. So regarding the biopsy procedure, so as we discussed in the past decade ago, the lung cancer was only classified as a squamous or adeno and other type. But now with the complete understanding of the pathogenesis, it has become very heterogeneous and systemic disease. You can see that there are almost more than 16 genes are available, and even more available, but for those treatments are not available. These, which are the genes name listed here, for each there is a specific treatment available, and that has changed the life of the patient. So almost 16 types of lung cancer we can define based on the molecular profile. And for this is just a brief. For ALK, there is a alectinib. For PD-L1 positive, there is atezolizumab, then brigatinib, crizotinib for ALK, gefitinib, and dabrafenib for BRAF mutation, and there is again osimertinib and pembrolizumab. These are nivolumab. These are immunotherapy. So there are many now targeted. Just a short summary, which has improved the life of the patients. So whenever we are doing the biopsy for the diagnostic procedure, we should know that in lung cancer patient, in addition to histology, sometimes we need molecular analysis to decide the treatment, and we need to choose the site of the biopsy very carefully, because if you take the bone, then we may be able to diagnose the lung cancer, but when we extract the DNA for molecular analysis, in that bone sample, the DNA extraction is very poor, so we can't characterize the molecular profile of the lung cancer patients. Again, in all kinds, as we discussed, in all types of lung cancer patients, whether squamous or non-squamous, we need to do either individual EGFR, ALK cross, and BRAF and MET mutation, or now we have shifted to do NGS-based panel, which determine more than 50 genes altogether. And if all these are negative, then we need to rely on the PDL1 to decide on treatment or chemotherapy or plus minus immunotherapy. And sometimes when patient get treated with targeted therapy, these are commonly advised to do re-biopsy. The purpose of this re-biopsy is to help in knowing the resistance to this targeted therapy, and to see whether any other target available to treat in the future. So coming to the real topic, what are the diagnostic challenges while making this diagnosis of lung cancer? Because lung cancer diagnosis starts from the histology, and now it has expanded to know the molecular profile also. So lung cancer patients are very fragile, because when they come into casualty, most of the time they may have breathing difficulty, and there is saturation drop, and they may not be fit for doing any biopsy. So we need to guide the patient not to delay their diagnostic procedure. We need to talk to our radiology team, because at our center, because of the heavy load, they get diagnosed this biopsy appointment maybe after 2 weeks, 3 weeks. So we constantly push our IR team not to delay, because these lung cancer patients are very fragile. In 48 hours or 7 days, they may deteriorate and may not be fit for any further therapy. So we need to ensure that the patient's general condition should not deteriorate. Then second thing is that, as we discussed, in lung cancer, we just not need whether it's adenocarcinoma or squamous carcinoma. We need to know the complete molecular profile in the form of EGFR or cross or doing NGS. And for each test, there will be requirement of tissue. So we need to discuss with our this radiology team to collect the adequate tissue, because doing the lung biopsy itself is a difficult procedure, and if we miss the adequate tissue and patient may not agree to go undergo re-biopsy, and then it causes a very difficult situation as for decide regarding the treatment without complete diagnosis. And third thing is the availability of tests. In Tata, luckily we have, it's a referral center, so we have all kinds of this testing method available. But there are centers in tier 2, tier 3 city where there is no pathologist available, or ISC marker is not available, and the NGS is a very distant thing. So we need to ensure all this, whenever we get any sample, so it should be sent to the good pathology lab and to do minimal ISC, and if it confirms lung cancer, we should proceed with the NGS. So at least in India, except for few centers or metro city, there is hardly ISC markers or NGS available. I have my colleague, those now who passed in TMH and now practicing in Aurangabad or some Nanded. They have very much difficulty convincing the patient to do this ISC, because it's costly also, and NGS test minimum it costed around 30 to 40,000 if you are doing a good panel NGS testing. So it is very difficult in current scenario to convince our patient to do NGS testing, or if we are practicing in distant site, to send a sample to Mumbai for doing all this diagnostic procedure. And last thing is the affordability. So again, this ISC and NGS is costing in few thousands. So in our population, obviously it's a major challenge to convince the patient it is a must test to decide, because sometimes they prefer not to do and only take chemotherapy. And in patients who are coming from periphery, we majority of time see medical oncologists or sometimes their surgical and radiation oncologists start chemotherapy, and after their first line failure they come to us, and here somehow we able to through NGO support or MSW support able to do the NGS test, and we are finding some targeted mutation and we start the treatments. So unfortunately, because this peripheral where these methods are not available or patients are not convinced to do this testing, lead to delay in the good treatment, and their lifespan also decreases. So at least in diagnostic challenges, these are the few we need to ensure that this procedure should happen in a good time, in a good general condition, and tissue should be adequate, and all the tests needed for complete diagnosis of the cancer should be in place. And third thing, if here also we have a lot of patients who there is no affordability, but still in Tata we have a good system of medical social worker support where we are able to arrange money for NGS and other marker, and we are able to get this. But if you go beyond Tata, there is life is very difficult for doctors or healthcare worker, where we see a burden at each places. So after the diagnosis, then lung cancer is the unique example of the personalizing treatment, because as we shown ki lung cancer, there is almost, if you go the molecular wise, there is at least 16 types of lung cancer based on the genes driver mutation detected. So for this, there is a now personalized treatment option. So coming in the 1970, where chemotherapy was the only option, and till 2000, when the first EGFR was detected and gefitinib has shown the improved outcome with the targeted therapy, the scenario has changed. And later in 2015, the first immunotherapy drug was approved, and again it has shown a dramatic improvement. So we need to optimize the individual patient's therapy based on the personal lung cancer profile. So basically, when we decide treatment, so whether we first see whether there is any driver mutation present or not. If not, then we decide regarding whether immunotherapy will benefit or not. If not, then we treat the patient based on the non-squamous or squamous histology. And so we should not rely only on the histology. So in addition to histology, we need to see all parameters, including PD-L1 and this molecular biomarker. So this is a short summary of the patients who get diagnosed with the different kinds of mutation. If EGFR positive, there are first generation and third generation drugs are available, including Arlo and afatinib, gefitinib, and osimertinib. If ALK positive, then again there is 1 to 3 generation drugs available from crizotinib, ceritinib, and alectinib. And for ROS positive, there is a crizotinib. Then BRAF positive, there is dabrafenib and trametinib combination. If all these are negative, then we decide on the PD-L1. If it is more than 1%, we can use pembrolizumab or other nivolumab, atezolizumab immunotherapy. So only if you see the EGFR in Western data, it is ranges between 13 to 15% of total non-squamous lung cell cancer patient. Coming to India, from Tata, it has been reported that approximately 23 to 25% of patients in India are having EGFR mutation. So out of every 4 patients, there is one patient who is EGFR positive in India. And this rises further to approximately 50% if patient is non-smoker, is female patient, and Indian or Asian origin having adenocarcinoma. So approximately every alternate patient in India likely that if she is female or never smoker, she may be a EGFR positive patient. And commonly seen gene mutation in the EGFR is exon 18 to exon 21. Out of this, majority are either exon 19 deletion or exon 21 mutation. And rarely we may say this resistant mutation in exon 20 or T790M mutation. And these are the some trials which has shown this targeted therapy are beyond having a very good response and this improving the life of the patient compared to the standard chemotherapy which was recommended in the past. Again, in the ALK rearrangement lung cancer, we can see that the incidence ranges between 5% to 8% in different locations. In India also, we reported approximately 6% of our patients are ALK rearrangement positive. Again, these ALK patients are mostly are younger patients, never smoker, and more commonly in males. And again, for this type of ALK mutation, there is a effective treatment available in the form of either crizotinib, ceritinib, or alectinib, or when these drugs fail, there is a now third generation drug available, lorlatinib. And these are the group of the lung cancer patient who approximately 65% patients are surviving beyond 5 years. And in EGFR, there is approximately 40% patients who are surviving beyond 5 years. So remaining these are the rare mutations, either ROS1 or BRAF, where the incidence ranges between 1 to 2%. And these are the few methods, either by FISH or ISC or NGS. And these are some targeted drugs available. And here again, the response rate is beyond around 60 to 70%, and their survival is again in the range of more than 5 years. So this is the activity of dabrafenib and trametinib in phase 2 trial, where it has shown more than 60% patient response to the this drug if we give the dabrafenib or trametinib combination. So it is our responsibility. We should not miss, even these are the rare mutations, we should test for them and try to find out these mutations. Again, if all these are negative, then we rely on the PDL1 and PD1 inhibitors. So this is the diagram where it is showing that this is the cancer cell with PDL1 ligand, and this is the our immune cell T cells with PD1 as a receptor. But in the presence of these PDL1 and PD1, this T cell is not able to kill the cell. So there was a now different kind of PDL1 or PD1 inhibitor, nivolumab, pembrolizumab, or atezolizumab, durvalumab, which inhibit this binding, and this leads to direct killing of the cancer cells. And in trial, this was the first trial of the pembrolizumab in the lung cancer, Keynote 024. So it has shown that at the 5 year, the survival rate of this lung cancer patient was around 30%. So approximately one patient out of 3 patients was able to survive beyond 5 years. So before this, the survival in patients who are driver mutation negative, the 5 year survival rate is hardly 2 or 3%. But this was the first trial which has shown if we are able to give immunotherapy patients who are PDL1 positive, approximately 30% patients will survive more than 5 years. And compared to the chemotherapy, you can see that the pembrolizumab, all kinds of side effects are very less. So in the current era, it is recommended to do all kinds of biomarker analysis and PDL1 analysis to decide the treatment based on the individual patient, not to treat lung cancer as a single disease. And in case of patients who are biomarker negative or PDL1 negative, then this is some general guideline. And basically they are treated with the chemotherapy combination only. There is no any effective long-term, but outcome of these patients are poor as compared to patients who are not receiving immunotherapy or targeted therapy. So coming to these treatment challenges. So again, as we know, giving any chemotherapy or immunotherapy, we need to have a patient in a good condition. And if we delay the diagnosis of the patient or patient defaults, then their general condition deteriorates very fast. So we need to continuously monitor the patient, and once the diagnosis is ensured, we need to start the treatment, not to delay the treatment, because in lung cancer patients, the window period is very small. So as early as we are able to diagnose the patient, we need to start the treatment. Again, the next point is complete diagnosis, because of the cost and patients' poor education, they are most time not able to do NGS testing or other ISC markers. So that leads to incomplete diagnosis and most of the patient out of the Tata, they are just getting treated with the chemotherapy, and that is giving a poor outcome. So we need to educate the patients and outside the patient and doctors who are practicing outside the Tata, means surgical oncologist or radiation oncologist, to do a complete diagnosis. Complete diagnosis means including all, not only histology, we should do a molecular profile with NGS or individual method by RT-PCR or FISH. And then third thing is availability. Because this lung cancer profile is changing so rapidly, now there are different, almost 16 types. Out of this, EGFR, ALK, and ROS drugs are commonly available in India, but there are still NTRK rate mutation, which are those drugs are showing more benefit than this EGFR, ALK, but unfortunately these drugs are not available in India. So sometimes there is some programs going on called compassionate access program. So we try to find out those program and ask our patient to get registered and get those drugs through that compassionate access program. So we need to educate the patient and family, and as well as outside doctors, there are drugs which are not available in India, but still it is available through compassionate access program, and they can get this dose drug. And the most important thing is targeted therapy or immunotherapy is the affordability. So you can see that the immunotherapy costing is around 2 lakh minimum per month. So, and if it is benefited, then patient need to continue for at least 2 years. So cost will be around 30 to 40 lakh per year. Means approximately it is costing around 80 to 1 crore, 80 lakh to 1 crore for the 2 years treatment. So it is very difficult in Indian scenario to sustain this treatment for 2 years. So recently this paper was published from Tata Hospital that immunotherapy affordability in TMH out of 15,000 patients was hardly 3%. So it is very poor scenario in our country that majority of our population is not able to take immunotherapy even though it is available. And again, the targeted therapy. So different, for EGFR it is easy. There are different drugs available costing between 1,000 the gefitinib and 1.2 lakh the osimertinib. But we have derived the method to combine first with chemotherapy so that it is affordable. But for all directed treatment like rizotinib is costing 85,000 per month. Again, it is very difficult for us to advise the patient to these drugs. But still we have We Care Foundation or some other support where we are able to give at least first generation drug. But for third generation alectinib or lorlatinib, it is not possible as to give those patients if they don't have any credit facility or insurance. And last thing is a clinical trials, because there is no clinical trials available in at least majority of the clinical trials not available in India. So we are not able to offer our patients any experimental drug. And nowadays there are many this experimental drug running outside the country and which are showing major benefits. So at least our patients are at very high loss because they are not able to we are not able to get these clinical trials in India. So these are this my talk regarding challenges in this diagnosis and treatment of these lung cancer patients.
Doctor, thank you. Any questions anybody has? If nobody has, I have a question. Actually, what happens, these patients who are taking this oral immunotherapy drugs, hardly they are getting admitted, or usually it is on OPD basis. So from nursing point of view, we don't understand what to tell them. We don't know what are we supposed to give advice to them. So any advices what?
So madam, this is our oral targeted therapy. Na? So we need to strictly monitor in the first month. So in the first month, whenever we start the drug, we are very careful regarding few common side effects like rashes or sometimes constipation or diarrhea, and few blood parameters like LFT and CBC monitoring. So initial first month we need to counsel the patient to do a regular test weekly basis for 4 weeks. And if 1 means they are tolerating well, then there is nothing to worry. We can just monitor them at every 3 months with same blood test. Only the initial 1 month is very crucial for us. But in our center, most of the patients are coming from outside, so they are not able to stay for 1 month. So we just request them for at least stay for at least first visit, and if first 7 days, 10 days they are tolerating well, then we are referring them, and still we are asking them to follow with the local medical oncologist. We are giving contact. If anything they face out, they should contact the local medical oncologist. So these drugs are very safe. So we are also not worried that patient will have any difficulties. So only initial 1 month is the challenging period, and most of the time, more than 95% patient we don't see any problem. So only so we means from our nursing team we just ask them to see the in the first visit to monitor the CBC, means ensure that patient should do CBC, biochemistry and ECG marker. Otherwise, no any worry regarding these targeted therapies.
Any particular way of taking the drug or before food, after food?
So most of these drugs are, ma'am, on empty stomach. Only hardly few drugs are where we need to advise the patient to take with the food. So either osimertinib or zepitinib, all are on empty stomach. Only seritinib is the drug which we advise to take with the food. Otherwise, most of these drugs are on empty stomach.
Thank you. Thank you. Dr. Ajay has discussed in detail about the advances in medical treatment of lung cancer. Many of the things which we were not knowing, no? Isn't it? You all understood many things now? Thank you, Dr. Ajay, for this enlightening session. And now we will see what are the advances in radiation therapy. See, radiation therapy is a therapy where most of us are not much involved into it. Nursing is very less involved in the radiation therapy.